So here's kind of an example of a variety of different types of cases that I've done. Starting on the top left, we see a lot of kind of straight implants. Um, we see upper six implants and lower five. But the implants are relatively straight in the bone. The teeth are relatively straight over the implants. And for at least from an X-ray perspective, this looks like a pretty straightforward case where you didn't have to do anything heroic. On the second slide on the top, you see really similar, especially the mandible, except now we've got some tilted implants to avoid some of this anatomy that gets in our way. And so on the upper jaw, you can see the posterior implants are tilted forward a little bit, and that's to avoid the anterior wall of the sinus. And then on the lower, you start to see some tilted implants on the lower, and that's to avoid the mental nerve and the mental foramen as they come out of the jaw. On the top right, you see a little bit more tilting on these implants. And what that means is there's just a little bit more anatomy that we had to avoid. And so we're still tilting our implants on the upper to avoid the sinus, sometimes to avoid the nasal floor. And we're tilting our implants on the mandible now to avoid the mental nerve and the inferior alveolar nerve. So now we've got a little bit more of a distal extension. We've got that supported with a metal bar. And so that's kind of the next level up. On the middle row to the left, we see a case that has a lot of tilted implants now. So we've got a combination of straight implants, we've got tilted implants, we've got pterygoid implants now that are in the back of the maxilla. We've got implants going through impacted teeth. We've got implants in the vomer. Like it's like a cornucopia of dental implantology here, but no zygomatics. So we did everything that we could using the patient's anatomy and tilted implants in order to avoid the patient having to use their zygomas for anchorage. On the middle slide, we see a case where the pterygoid bone was used, the pterygoid plates to give additional support for the distal extension of the upper jaw. On the lower, we see six dental implants with two tilted ones in the middle, and the rest of them look pretty straight. On the center right side, we have a case of zygomatic implants and tilted implants and straight implants and short implants and pterygoid implants. So there's a lot of options on a case like this for being able to get anchorage for your dental implants so that you can give patients teeth the same day. On the bottom left, we see another combination of zygomatics and tilted implants. We have some transsinus implants here. We have some zygomatics and pterygoids, and then on the lower jaw, we have that same combination of straight and tilted implants. And then the last two cases are kind of the most complex that I would see. These are zygomatic implants, pterygoid implants, transnasal implants, transsinus, vomer, tilted implants. I mean, we've got everything but the kitchen sink on these two. And then the last one on the bottom right is kind of our most complicated case. These are patients who have little to no bone left anywhere in their maxilla. So this is a pterygoid case. We've got quad zygomas. So we've got four zygomatic implants from the cheekbones coming down into the mouth. So this is a person, at least on the upper jaw, that has little to no alveolar bone left whatsoever. They've probably been in a denture for 40 years, and they're looking for some sort of solution so that at least we can provide some sort of solution for them. So I'll go through a couple of basic surgical slides so everybody understands what full arch implant dentistry is like, at least at Full Arch Masters. So the initial incision is a crestal incision. You can see on the palate here, I've placed two metal screws on the palate. These form the base of our digital workflow. This isn't a digital workflow lecture, but just understand that we place those before surgery, right before surgery, so that we have something as kind of like a geometric home base. So I make a crestal incision across the ridge, in this case from molar to molar and around the existing teeth. I like to raise a buccal flap afterwards so that I can get really good visualization of the tooth roots. Sometimes we have tough teeth that we need to take out and we don't want to blow out all of our buccal bones. So I like to raise my buccal flap first so that I can see where I'm going. Then I proceed to take the teeth out. Excuse me. Taking the teeth out is pretty simple in a full arch case because there's usually not too many of them left. And usually the ones that are left are either infected or have periodontal disease. So they're usually pretty simple to take out. In this case, I took these roots out in probably about maybe 8 to 10 minutes. But having that buccal flap already open and pushed up really allows me to get the teeth out quicker. Once I have the teeth out, then I raise a palatal flap. And by doing this, I'm able to really isolate the ridge and get the case ready for implant placement very quickly. Once I have the palatal tissue sutured together, then it's easier for me to reflect the buccal, and I perform what's called an alveoloplasty. An alveoloplasty is bone reduction. It's very important that we reduce enough bone on these cases. Usually, working with the Full Arch Masters Lab, we give detailed instructions on how much bone they recommend removing for each case. So we make measurements, and then there's a variety of techniques that we can use to remove bone. I like to use ceramic burrs because they don't overheat and they cut a very, very flat table like this. Some people will use saws. Some people will use like rongeur, bone file. There's a lot of different ways to remove bone. At our courses, we teach kind of a handpiece driven acrylic burr, ceramic acrylic burr to really mow down that bone in a quick, efficient, clean way, but also to have it be very, very flat for our implants. Once the bone is reduced to a sufficient level, then based on our plan, which we'll go through some of the CBCT planning in a bit, but based on the plan, we freehand our surgeries and we place the dental implants into the ridge in the configuration that we planned ahead of surgery. So in this case, I placed 4 dental implants, and as soon as the implants are in, then we put what's called our multi-unit abutments on top, and those are the base for our future teeth that are going to be delivered at the same time. Once I have those abutments in place, those are torqued down according to the manufacturer's specifications. I use a lot of photogrammetry in my clinic. If you don't know what that is, it's a separate scanning system solely for implant positions. So it only does one thing, and it does it very, very well. It gives you your exact implant positions down to 5 or 10 microns. So you get a linked data set of all 4 implant positions in space that you can use in exocad to build your immediate load bridge. After I take that photogrammetry measurement, I put special healing caps on, which are tissue scan bodies. They're basically scan bodies that are very, very short. We're not using them for implant position. We're only using them as a reference to link them to our exocad case. So we put the scan bodies on, we suture everything closed like this, and then we take an intraoral scan, like with a Medit or Trios or Prime Scan or one of those intraoral scanners, and we scan this in the mouth. And this allows us to in the lab to link our design to the surgery and create a printable prosthetic that we can put in each day, same day. On the lower jaw, I tend to do half of the jaw first and then the other half. The reason for that is I don't have a pallet like on this. If I go back a slide, on this I have that home base of those 2 screws on the pallet. Those act as our scanning base so that we can link our pre-op scans to our post-op scans. Even though everything in the mouth changed, the position of these 2 screws did not. So in the laboratory, when you look at exocad, you can layer your scans on top of each other based on common geometry. And so on the mandible, we don't have a common geometry because the tongue is in the way, and there's no way for us to put a rigid marker in the middle of the mouth that doesn't change. So we have to use something else, and we can install markers on other parts of the mouth. But in a case like this, where there's no room for any markers like that, then we just use the teeth. And the way we use the teeth is by choosing which side we want to leave, and then we do the other side first. So in this case, I left the patient's right side, even though it's mirrored, so it looks like left here, but it's the patient's right side, and I took out the periodontally involved teeth, and I smoothed the bone down on one side, and I placed the 3 dental implants that you can see on the right side. So I placed site 26, 28, and 30, but I left the one side, the entire left side untouched, and I also left the second molar untouched. So that when we scan this or take an impression of this in surgery, we have the pre-op to link to because it has all the same existing teeth. But then we also have the implants to link to for the second half of the surgery. So we kind of create a bridge between pre-op and post-op by leaving half of the teeth alone and doing one half of the surgery at a time. After you get that kind of mid-operatory scan, Then you can proceed to do the rest of the surgery. In this case, I did the other side. I decided to leave those second molars as an additional reference at the end, so you can see them in the back, and then I take those off at the take those back molars out at the very end. So you can see again, registering the implant positions during surgery using photogrammetry. This is much more accurate and more reliable than any other method for registering where your implants are in surgery. Um, After the photogrammetry measurement, just like we did for the maxilla, we're going to come back and now suture the lower jaw and take a tissue scan record with those same caps. So just kind of as a summary, you install your markers if you're going to use those, which were those screws on the palate, then raise your buccal flap, either extract all the teeth if you're able to use markers, or half of the teeth if you're not able to use markers. Then you raise the rest of your flap and get access to the ridge so that you can reduce the bone. Then you install your implants and your multi-units, and you do a mid-op scan if you're doing the mandible. You do your photogrammetry scans to get your implant positions, and then you close the case up with suturing, and you scan again at the very end. So that's just kind of a brief overview so you guys understand kind of the basic surgical principles for a standard case. We're going to talk a little bit more about the advanced surgical cases now. We're going to cover some anatomy and some surgical techniques, some of the complications associated with this, and then some of the unique prosthetic considerations that these cases provide. This is a great quote from one of my alumni and friends, Justin Scott from Atlanta. He said, "The goal is to be able to do 99.9% of the cases." And I think that's true. I think that there's some patients that just don't qualify for this. I think that either they're medically compromised or they just have absolutely no bone whatsoever. Yeah, you can come in. So between the advanced techniques that I'm going to talk about now, I think it's very, very possible for the full arch dentist to be able to do up to 99.9% of the cases. So these are the main advanced surgical techniques that I use in my clinic every single day. I'm not going to talk too much about zygomatic implants. I think that's a completely separate subject that we can spend an hour on at a different time. And the reason for that is between transsinus implants, pterygoid implants, and palatal approach implants, I have virtually eliminated the need for zygomatic implants in my practice. I still have maybe 5 or 6 cases a year that need zygomatics, but it's getting less and less every year. And the reason for that is I'm getting better at doing transsinus, pterygoid, and palatal approach implants. And it's the risks associated with these other procedures are far less than the risks associated with zygomatic cases. And so I think that zygomatic implants slowly will start to fade as a viable treatment option. There's still going to be some patients
But again,
that need them. As I'm running a full arch practice that does full arch cases every day, even I find myself doing them less and less. So let's talk about transsinus implants. These are very valuable implants for increasing AP spread in severely resorbed cases, but they're very, very tricky to do. The key is really in the diagnosis, the treatment plan, and the surgical technique of these. First and foremost being the diagnosis. There's very, very strict diagnostic criteria that I use to choose someone to receive a transsinus implant. And we'll talk about that. And then the treatment plan and the surgical technique is very, very, very tricky and very technique sensitive. It's very easy to go for things to go wrong. So let's talk a little bit more about transsinus implantology. So transsinus implants are really just a regular